Hi, I'm Dr. Lisa Catarula, and I'm here with Dr. Brian Willett, and this is Scoliosis Specialists Podcast Episode 2. And today we're going to talk about rigid bracing. You know, we do a lot of talking about the importance of the dynamic flexible brace that allows kids to be active and prevents any muscle weakness or atrophy. But there are times that rigid bracing is completely appropriate and actually very, very necessary. So we're going to talk today about when those times are. When do you use rigid bracing? When do you use the spine core flexible brace, and what that's all about. So, Dr. Brian, why don't you let us know, educate us a little bit about these braces that we have here, and when we would use a hard brace, and what that would be, when would that be appropriate?
So I'd like to start off by saying that we always use a dynamic brace. So it's vital that we use a dynamic brace to treat scoliosis, even if we use a rigid brace. Because we always need that neuromuscular re-education, right? I mean, that's important. You can't just put a hard brace on somebody and push it into a position that you want, because it won't hold. If you don't recruit new muscle, don't retrain the nervous system, nothing's going to hold, right? And so at the end of the day, we're left with where we started. And traditionally, for hundreds of years, we've been using rigid braces. But the goal was to just stop progression. So if there was, hey, we're just going to stop progression, we stopped progression through all the growth, that was a win. It was a victory. Everybody was celebrating, right? But now with dynamic bracing, we not only try to stop progression, but we try to get as much correction, any kind of correction that we can get, either using spine core dynamic bracing in combination with a rigid brace. We want these corrections to hold.
Right. And I think it's important to note, too, that we do not put kids in rigid braces during the day, right? I mean, it's not like they're going to school wearing that type of brace.
No, and it really depends on aging, and there's some big no-nos with that, right? And we just don't offer it in our clinic. We've been treating scoliosis for, 30 years. And we just do not offer full-time rigid bracing, and that's for a reason. It's just not that we don't offer it.
It doesn't work.
It doesn't work. It's not, if it has worked in the past, and what's worked in the past is it stopped progression, right? So stopping progression in scoliosis is your victory. So the problem with having a child in a rigid brace 22 hours a day is, what are you doing with the growth, right? I've seen kids come out wear a rigid brace for 5 years, 22 hours a day. They have big heads, big legs, and their whole thorax.
I know. It's so sad.
Is
underdeveloped.
It's underdeveloped.
Yeah.
So it's a huge problem. And so what else is underdeveloped? Are you just looking at the patient saying they're underdeveloped? But think about what's inside, the internal organs, mostly and mainly the lungs. And so these kids have pulmonary insufficiency as an adult. And if you read the research, it even decreases their lifespan. So if you know you're going to decrease a child's lifespan, let's just get them through today to get to tomorrow? Or are you looking at the life of that patient, right? And until the end? I mean, you want to...
Absolutely.
Right.
Yeah. And quality of life, too.
Just because they have scoliosis doesn't mean they have to have a poor quality of life. It doesn't mean they need to die early, right? It just needs to be treated correctly. So we like to use a dynamic brace during the day just to the whole neuromuscular re-education system in the body, it needs to be trained.
Well, and the great thing about the dynamic brace is not only clinically is it's far superior to the rigid bracing you were talking about, but the compliance rate with spine core is so high because the kids don't mind wearing it. It fits underneath their clothing.
Correct.
They can play sports. It's comfortable, infinitely more comfortable than a full-time rigid brace.
No, absolutely, right? Absolutely. However, today's podcast was really based on the rigid bracing. When do we use it? When don't we? So we can just kind of right here and right now say, if you're an adult and you're in a rigid brace, we say get out. We don't ever want to say, hey, I disagree with your doctor and I don't, it's not my specialty, and I'm not going to make this recommendation. And your doctor recommended a rigid brace, and you're an adult, and I don't want to step on toes. But in this case, I do. I want to step on toes because if you're a doctor, and you know scoliosis, and you're putting an adult in a hard brace, these spines, adult spines, are rigid. They have degeneration. They have arthritic changes. They have more arthritic changes than somebody without scoliosis because of the amount of pressure due to the curves, right? So they have bone spurs. They have degenerative disc disease. They have it. They know it. That creates a rigid spine. So now you put them in a hard brace full time where they get muscle atrophy, ligament laxity. The spine's going to collapse, or you're going to make that spine more rigid. I say I'll step on toes in that case.
Well, and you're not really telling the patient anything they don't know. I mean, we get calls all day long from adults that have been put in rigid braces, and they're not getting better. They're not feeling better. They're not able to move around any better. The quality of their life has not improved. So
they're miserable.
Really, yeah.
They're miserable.
Yeah.
So we just don't do it. We don't offer it. So people will call and say, hey, I heard you have a better rigid brace. I'm in one, and I want a better one. And you know, it's not available here.
So let's tell our viewers, when do we use these? What would be the indicators to put a child in a rigid brace? How many hours a day might they wear it? Let's talk a little bit about that.
So we like to use it at night, a nighttime only overcorrective rigid brace. And we're talking of different types of rigid braces. So we have one here. We like the CMP corrective movement principle. It's a three-dimensional. So if we look at it, we have dimensions in here. We have rotations and torsions that we can do. We also have a certain void here, an opening. And there's reasons for this. So what's an overcorrective nighttime rigid brace mean? Well, the idea is not to just enclose the spine and hold it from progressing. There are braces out there that do that, right? And they wear them 20 hours a day. So we want them, overcorrect them. It's not meant to be walked around in because it's overcorrecting them. It's bending them.
And that's a good point, because actually in these braces, the kids, it would be impossible to wear it during the day, right?
Yeah, they couldn't wear it all day. Right. Their posture's off. Everybody would look at them because we're overcorrecting. We're bending. It's almost like taking a bending x-ray, but you're putting them in a brace. And that's the way they're sleeping. And then the spine, when they sleep, they lay down, they're supine. Their spine tractions out as well. And as they tighten it, it gets even more correction. So the key to these, though, is only if a child's growing. If a child's not growing and has no more spinal growth, we don't even use these, because they're at that point, you'd just be selling a brace to somebody that wants some kind of treatment for scoliosis. The idea is that you open the curve enough in a growing child that the concave side, that's the inside of the curve where all the pressure is, right? So when that child grows and they have all that pressure on the inside of the curve, the outside grows in the next growth spurt, but the inside doesn't.
Right.
And that's layman's terms. I mean, it's actually the posterior lateral aspect, delay and ossification centers, but nobody understands that. Basically, layman's terms, the spine is growing, the vertebrae are growing like a piece of pie, right? And we want it to be like a block. Instead, it's like pie. Well, the inside, the next growth spurt, because of all that pressure on the inside of the curve, it doesn't grow. The outside does. The curve gets worse. Well, when we put them in this brace, we can force it to where we open that inside up, put the pressure on the outside of the curve, take the pressure off the inside of the curve, so that next growth spurt, we get growth on the inside, we get correction.
So what are some of the other differences with this brace? Because, you know, we get calls from parents that say, well, I have a nighttime brace, right? I'm looking for something during the day. I have a nighttime brace. So you did mention the overcorrective component, which is huge, but what else would be different about this brace?
So there's a lot of things. One is, especially with a growing child, we want to deal with rotation. Everybody knows scoliosis has a lot of rotation and torsion, and everybody mentions rotation. If you're not treating rotation, you're not treating scoliosis, right? So we can treat the rotation by pushing the rib cage around and then open the curve, but we have to, when you open the curve and you shift it and you want correction, you have to push it somewhere. And if you have a fully encased brace, you're pushing into a wall. If I
Nowhere
push
for
you
the
into that
rib
wall,
cage
you're
to
not
go.
going anywhere. So we have this huge opening. So one, it allows them to breathe much better. They'll never get pulmonary insufficiency because they can breathe. Also, as they're growing, it can reform the rib cage because it has a place to go. Right? Also, because it's nighttime, we can put all this padding inside, right? So if you can have all this padding, that's all this white stuff, and not just the plastic, it's much more comfortable. We also have a locking mechanism in the front, and that's so if they're switching and they're turning, so, turning over side to side, stomach sleepers, whatever, they're fiddling around, keeps it in place.
So I want to emphasize something that you said, because you were talking about the three-dimensional component of this type of brace versus other rigid braces, which would be really like a two-dimensional treatment for a three-dimensional problem. But we get calls often from parents, and when they've got these young adolescent girls, appearance is a big issue, right? You oftentimes see that scapula protruding, and the parents want to stop or change the deformity of that rib cage. So I think what you're saying is that if we catch the curves early enough and we can use this type of intervention, we're really sort of remodeling the spine, right? We're not going to have that level of deformity that's so obvious.
We've got the technology to be able to remodel. It doesn't always happen because
Right.
people don't treat the scoliosis soon enough.
Right.
And when it's a large deformity, it's too much remodeling to have done.
Right.
So again, we go back to our last podcast where we said, get treatment early.
Yeah, early intervention.
Don't wait.
Yeah.
It's like the last patient we just saw today, right? Mom was in a Milwaukee brace, the kind that goes underneath the chin.
Yep.
The son had scoliosis. Because she had it, she brought him in early. It was a small curve. We straightened his spine. The little brother has it. The little brother had a small curve, 18-degree lumbar curve. They would be told to wait.
Absolutely. They're a perfect example. Perfect.
So 18 degrees
Straight spine.
on an 8-year-old
Yep.
is going to grow out? No, it's
Well,
not going to
with
grow
our
out.
treatment, it will.
Right.
Yeah.
But if you wait and see and you do nothing, 18's going to 30, 40, 50. It just does. So we braced him, and what did we get on the post x-ray today? We have a straight spine. It's nice to do. And he doesn't need this.
Right.
He can use spine core only. He doesn't have to use this. But it's nice that we have this ammunition to back up something to say, hey, we didn't get as much correction. We're using spine cores, that dynamic braces, that thing to stop the curve. We got a little bit of correction, but we've got a high risk of progression. We've got 5 or 6 years of growth. If we can do a nighttime overcorrective brace, we might get them to be able to grow straight.
Right.
And that's key. And that's extremely important. And that's why we use this.
So I
CMP.
wanted to mention one other thing, because you just briefly mentioned the locking mechanism.
Yes.
Can you explain to our viewers why that's so important? Because a lot of people have braces. The people at home that have rigid braces, they think their brace is like this. Even what we're saying,
Yeah.
it kind of looks to them like this. But there are some key components. You mentioned the three-dimensional treatment. But the locking mechanism is really very, very critical to the effectiveness.
It is,
of this
because you
brace.
want there's certain when we do a 3D scan of the patient, and we send that scan and X-rays out to the CAD guy. A guy sits at the computer and he looks at the scans and he looks at the posture and he looks at the X-ray. He's putting everything together and putting pressure points at certain areas. And this is extremely important. And then when we put padding in to increase rotation, torsion, and shifts, we put that padding in, we want to be precise in where we put it. And so if you don't have a locking mechanism and it starts to shift or move, then those positions and places aren't there anymore, right? So you're not going to get the same treatment.
Right. And you would imagine that if we're wearing this to sleep, you're tossing and turning, moving around at
Correct.
night. So there's a high probability that it is shifting
It will
if you
move.
don't have that locking
It will
mechanism.
move.
Yeah.
And I see other locking mechanisms that people have tried. They don't want to steal this one, so they try others, and you can still move it and shift it. This you cannot move.
So let's also talk about, we talked about this type of brace they would wear to sleep at night. How long would a child need to be sleeping in this brace typically?
Well, we like to use this brace about 10 hours a day. Whether if they're sleeping 8 hours, then they need to sit up on pillows and watch TV for 2 hours before they go to bed. But we like, when we have to use a nighttime overcorrective brace, we like them to use it 10 hours.
And are they wearing it for 6 months or a year, or when are we wearing it?
As soon as it's safe to take out,
Yeah.
right? So as soon as they're finished growing, the spine's finished growing, they're safe to take out. And it's really at that point, when the spine's finished growing, at that point there's really no use to it anyway, right? Because any changes at that time will not hold.
Right.
So this is why I don't understand why adults are wearing hard braces. I don't.
Well,
So-
yeah, it's never going to be something that's going to help them.
I welcome any doctors out there that are putting them in braces to give us a call and talk to us about it and share with me any research they have, because we are constantly reading research. I mean, on scoliosis, it's all we do. And people go, "Oh, when's your last book you read?" I don't read books. I read research papers. And so I haven't found one that says that rigid bracing is good for adults. There are none. They don't exist. So why is that happening? I don't know. And then we also like to use this. This is really handy. This is called our CMP Light brace. The material is different. It's more like a hard styrofoam. It's almost like the inside of that. But we can use this for syndromic patients like Ehlers-Danlos syndrome, which is a connective tissue disorder. We have a 3-year-old. We painted this. We got it a Batman. It's all done Batman. He thinks he's wearing his armor, and he's has no problem wearing it, right? And so sometimes we have him in this, and we're also using spine core on him as well, because we don't want to have any other issues. But this is a little bit softer. People are in wheelchairs.
Right, that's what I was going to
They
bring up,
can't
'cause we
communicate.
get quite a few calls from people with.
What if you got a child that can't communicate and you put them in a hard brace and they can't breathe?
Yeah.
And they can't communicate, they can't breathe, right? I mean, how horrible. I mean, I couldn't walk away, right? You can't do that. So this is kind of nice because it can expand with them, but it can still give them that support while sitting in the chair. And it's I think it's the only one in the market. I've never seen one like this before. And people in wheelchairs really don't mind wearing this
They do very
at
well,
all, and
yeah.
it gives them the support that they need. So there are different kinds of braces that you can use to treat. And I was speaking with a patient this morning, and she said, "What about just doing chiropractic care?" And I'm a chiropractor, so I love chiropractic care, and I think chiropractic care is great for anyone. And I know a lot of, people might say, no, you have a curve in the spine. You shouldn't have it adjusted. I mean, if you know what you're doing, you should have it adjusted. We want motion. Motion is life. We want motion to the spine. Chiropractic care puts it there, but it doesn't stop progression, right? Physical therapy, great. Doesn't stop progression. So when we're treating scoliosis, we really need to treat it with bracing. And it's really the only thing that's been proven to work for adolescents. Adults have options, right? Adults have options. If they're getting a result and they're not in pain anymore because they went to physical therapy, they don't want to do a brace, they don't need to. If adult wants to do chiropractic care and there's no risk of progression and they're doing well, keep doing it. They don't need a brace, right? But in 30 years, it's just doesn't seem to be the case, right? What do you usually see with these people? An adult that's just doing chiropractic care, eventually
They progress.
they progress, they get worse, they're in pain, they go and they do other things. So you've got to think, how long have those patients had these problems? And
It's not going to be a quick fix, clearly.
It's not a quick fix.
Well, and I think that's the bottom line. So if you have a child that is currently has been diagnosed with scoliosis, if they are in a brace or not in a brace, give us a call at the number on the screen or visit our website, scoliosisfix.com, and let us explain to you what we can do to help and make the appropriate decision in terms of what type of brace is best for your child.
And x-rays are great. Did you mention x-rays? Send us the x-ray.
Yeah, send us the x-rays.
Download the x-ray right on the website. You can download it, I believe, right?
Yep,
On
you can
our
upload
website.
those images to us, and
Now, when we're
happy to
when
do
we're
a
talking about
consultation.
adults, and we get this all the time, right? Some people are older and they're like, download on your website. I've got a flip phone, right? I don't know how to download to your website. So if they've got a flip phone, get a friend who's got a smartphone, take a picture of your x-ray. You can text it to our assistant, and our assistant can just get that text. As long as we have that x-ray in front of us, we can do a phone consultation, no charge, right?
Yeah,
Save them their time, save them money, and find out if we can help.